How fantastic to be here. I've had the best day. Have you had the best day? Yeah, brilliant. I started off this morning in a group of allied health directors and key strategic leaders from health and social care talking about our national delivery plan for allied health. And I'm going to share with you a little bit about that today. I know that not all of you are from Scotland. How many people are from other parts of the United Kingdom? So most of you. So don't worry, this is not heavy on the Scottish policy. I think it's important to recognise the divergence sometimes of the policy agenda within the different countries, and yet the convergence of the challenges that we face in supporting older people to live well, to live lives with meaning and purpose, and to use the skills and talents of the whole workforce to do that in an affordable and sustainable way. So I think those are common aims and purposes. Would you agree? Yeah, and we live in challenging times, but with those challenges come some phenomenal opportunities. And I really do mean that. I think I'm a born optimist. I don't think I would do this job if I wasn't. And I'm sure most of you are too. And I think that one of our challenge, I guess, is to reignite our passions and energies. Maybe the people in this room already are ignited and activated. Maybe it's the people that you work with. Maybe it's some of your other professional colleagues that we need to reignite and activate around the opportunities for this, because it's easy to get dragged down with some of the negativity and some of the very real, tangible difficulties of delivering good quality services in challenging times. But we've got 20 minutes together today. I don't want to talk at you. I want to hear a little bit from you as well. So I want this to be an interactive session. I'm going to start with a few questions just to get you in the mood. Will that work? Oh, come on. Right, first of all, I want to know how many of you have a social care background? Okay, good. And the rest, health? Any third sector, other organisations? So, a few partnership, great. Does everyone in the room work with older people in some shape or form? Well, that's good, I'm in the right place. Excellent. How many of you believe that OTs can provide many of the solutions to some of the challenges health and care organisations face at the moment? Good, okay, some of you not convinced, okay? Hopefully we'll change your mind about that. How many of you think OTs are underappreciated? Okay, so some of you think we get good, excellent, okay. So let me start with a little bit about the policy. One of the things, I guess, that motivates me and is my driving force, even in a policy environment, is that I believe that what we do makes a difference to the people and the families and the communities we serve. And I'm sure that's part of your core purpose as well. One of the challenges we have, I guess, is that we're living in shifting sands, uncertain times, and actually sometimes the context in which we operate doesn't always offer us all the opportunities we would like to influence the direction of travel. Sometimes people don't understand the added value that allied health as an entity brings, or any of the individual professions within allied health. So we took a very specific decision to develop a national delivery plan for allied health professionals as a whole, so that what we could do would be twofold. One is to showcase the value that allied health brings to health and social care, and in particular to the integration agenda. So most of you will be aware in Scotland we have legislation being developed at the moment to integrate health and social care. Ministers are keen to remove any barriers, perceived barriers or real barriers, to financial integration, to make sure that services really do feel joined up. And we all know the challenges of working across agencies, and who's the budget holder that sometimes get in the way. So that's one of the main drivers. But actually the proof of the pudding, if you like, the prize out there for us to grab is to improve outcomes for people that use services at the end of the day. If not that, then why would we bother? Because it's a lot of work, it's a lot of upheaval, it's a lot of moving of deck chairs, it's a lot of positioning for people to look at, how they will get control over those budgets, etc. We've got a lot of work to do to make sure that we deliver the aspirations of integration and not just bring budgets together. So what was really important for us to do was to make recommendations not about big picture or strategic direction, but very specific and measurable things that we know we can deliver. And we looked at all the different opportunities there were, I guess, for us to do things. And some of our critics said, well, we're not saying enough about learning disability, or we're not saying enough about this clinical area or this specialty. And yet we knew that what we needed to capture in this document is what can we do for the organisations, the people and the communities we serve. And the single biggest challenge the organisations and people we serve are facing is to support older people. With the rising demographic, with all the increased comorbidity, multiple morbidities that people have, people living longer with all of these multiple long-term conditions, which is a success story, isn't it? That people are living longer. But of course, one of the challenges, I guess, of working in this field, and you don't need me to tell you this, is that the dialogue, the narrative around all of this can feel a bit negative, can't it? It's the burden of care. It's the challenge of providing services. It's the difficulties of providing care to older people and ensuring the quality of that care. Some of you see the Panorama programme last night. So it's a kind of ongoing public debate, isn't it, as well, about what do we do about the problem of older people? Do you think older people are a problem? I don't think they're a problem. I think it's a fantastic opportunity for us to celebrate the value that older people bring. And to enable them, through the skills that we have, to live lives with meaning and purpose, and to enjoy quality of life, adding life to years, is the expression that's been used before. So we very carefully chose a title of allied health professionals as agents of change in health and social care. How many of you have heard of Thomas Kuhn? Anybody? No? How many have heard of the expression paradigm shift? Well, very, very helpfully, the 50th anniversary of Thomas Kuhn's book, which expressed what a paradigm shift was last year when we launched the National Delivery Plan. And in his book, if you're interested about the science, the book is called The Structure of Scientific Revolution. And in his book, he sets out what he believes to be the factors that create and sustain and support a paradigm shift. And he says it doesn't happen without agents of change. And I believe that we are agents of change, but we need to create the right circumstances in order to be activated around that. And one of the challenges we have is we're busy being busy. It's quite difficult to lift your head and think about how do we want things to be different. Especially when it's stressful and challenging, etc. We can busy getting through the tasks. Do you know what I mean? We see the work, we come in and we do the work, and then we go home. And actually, our gift, if you like, to health and social care is to be facilitators and enablers of that paradigm shift, as much as we are facilitators and enablers for people's lives and the people we work with and families and carers. Does that make sense? So I don't need to explain to you what a paradigm shift is, do I? I think that we are engaged in a whole range of, it's not just one paradigm shift. I think that society is engaged in a whole lot of paradigm shifts around media and technology and a whole range of things. And the pace of that change has ratcheted up significantly. But just a few of those multiple paradigm shifts. We're moving, particularly, I know in Scotland, I can't speak for the rest of the UK, but we are really trying very hard to move from paternalism to consumerism in healthcare, aren't we? And partnership. We use partnership a lot in the way that we develop policy, the way that we work in the NHS in Scotland. And it's hard sometimes because one of the other paradigm shifts is the paradigm of professionalism, the keepers of the knowledge. We're the experts and we know what's best for you. And we're trying to move from that paradigm of being in charge, being the keepers of the knowledge, to actually patients as experts in their own condition. Nobody knows what it's like to live with that condition as much as that individual does in their life and what matters to them. And so that the language we're using in the context of our quality strategy and priorities in the NHS is it's not about what's the matter with you, it's what matters to you. Isn't that music to the ears of occupational therapists? Isn't that the language we've been using for years? Yeah. So it's lovely, but we're in the midst of that. It's kind of difficult, it's challenging. especially when the pace of change is hard and the pressure to deliver is hard. We have hospital-centric care, don't we? We invest in the palaces of ill health. It's where it all happens. It's where all the hot issues are. It's where all the challenges are. And yet, the future of healthcare is not disease-centric. It's about people with multiple long-term conditions. It's about helping people to stay at home. It's the areas where allied health, and in particular OTs, have significant expertise to play. We can support people in that way that not only benefits that individual and their family, but that benefits the organisations from a cost avoidance perspective. So much better for the individual's quality of life, but so much better for the organisations as well, to avoid inappropriate, unnecessary admissions to hospital or care. Again, you don't need me to tell you that. Older people can't use technology. It's another paradigm shift, isn't it? And we know it's not true. I just this morning was hearing a presentation from an OT who's led some fantastic online work to support self-assessment and improve access to services for equipment and adaptations and a whole range of other services. 46% of the people who use that service are over 65. We need to get with the programme. Yes? How many of you have websites for your users? 2, 3. Ooh, not many. How do people know what you do? How do they access you? If you wanted to know about something in a service and where you would go, where was the first place you would look? Boys and girls? Yeah, come on. This is us now needing to start thinking. This paradigm affects us and how we do our business. And not only in terms of accessing information. Older people are now using telecare to stay at home. It's supporting people with dementia. It's supporting people with very complex needs who need to monitor their conditions. It's supporting us to free up clinical or professional time that can be better spent doing other things, but still keep in contact with those people and make them feel safe and be able to dip in and out of our advice and support when they need it. So I'm going to ask you another question then, because this is quite critical to the paradigm shift. How many of you think the most important thing we do is to spend our time directly working with patients and people who use services and their families? Go on, don't be shy. A few people. Okay, so I would say maybe about... Do that again, because you're all a bit hesitant, like, no, not me. Do it again, show me your hands. Okay, so I would say maybe a third, maybe a quarter to a third of you are saying that's the most important thing. I'm going to ask you that question again when we come to the end of the time, and I'm just watching to see, because I'm timing. How am I doing? What have we got? We're okay? Okay. So we've talked about integration and the fantastic opportunity. We're the bridge. OTs are the only profession employed in both organisations. We're the connectors. And we do it every day, don't we? We connect people, we matrix work, we bring people together to provide solutions for the people who use our services. But we need to step that up a level. So we're not doing it on a case-by-case basis. We're thinking about how can we make this work every time for every person. We need to try to reduce unnecessary variation. We shouldn't have to fight the fight every time the same thing comes up, should we? Okay? So there's an important opportunity here for us to understand the role that leadership plays in positioning the contribution that you make. And our national delivery plan was about making visible that contribution, making visible the added value that people bring to the table. Over the years that I've been involved in professional conferences, not just OTs, but all the other disciplines, there's been a fight for allied health to get a seat at the table and for people to understand what we do as individuals. What do we do? What are the things that we do? So that they can associate our profession with the things that we do. But actually, it's not just the things that matter, is it, to people? It's not the what we do, it's the so what. So what that matters. You don't buy a washing machine just because it washes your clothes. You buy it because it allows you to go to work with clean clothes. You buy it for the added value that it brings to your life, not just the functions that it performs. Do you get what I'm saying? It's the so what. And what makes our work memorable to decision makers, to strategic planners, is to understand the so what. So I think we need to move on from trying to describe the what all the time. Maybe we're not doing too much of that anymore. I think life has moved on. But we need to be much clearer about the so what. And how do we get to those nuggets of information, those things that people will remember about what we do? So the next thing I want to talk to you about is improvement. How many of you have been involved in improvement programs? Just a few, okay. We've done a lot of work in improvement in Scotland, particularly with different types of improvement within health and social care. In the NHS, we've had a national quality strategy that's focused on safe, effective, person-centred. And what I have learned from being around those different programmes is that while data is not a motivator for people to change in its own right, it nevertheless tells a really important story and helps the narrative about the so what. So we have a patient safety programme that's been able to show a number of different boards across Scotland where they have no ventilator-associated infection for 550 days. They have no HAI in the particular ward, unit, department, service for 350 days. Part of the National Delivery Plan was about identifying, so what are the stories we want to tell? What are the stories we want to tell about the added value that we bring? And some of those stories about the value to people who use services, but some of the stories are also about the cost avoidance, the cash releasing activity. Cash is king at the moment, would you agree? Anything that we can do to help our organisations that are under pressure, we should be doing. That's what we're employed not just to deliver direct patient care, we're employed to support our organisation in its mission and purpose and in delivering its values. So how is our activity aligned to the purpose of the organisation? Or are we just busy being busy treating patients every day? Working harder, but not necessarily smarter. I'm putting some challenges out there. And also, one of the things that is about that whole process of where in the patient or user's journey are we intervening? Are we intervening upstream, where we can do preventative work, where we can support that person to stay independent, to avoid falling, to stay at home and live with meaning and purpose? Or are we intervening downstream once they've already fallen, they've got the fractured neck of femur, they've been admitted, and we're helping them go home? Rhetorical question, but have a think about that. Where in the journey are we intervening? Is it where we can make most of a difference? Or do we even know? Are we just doing what we've always done? Do we know where in the pathway would be better, but we can't free ourselves up to do that because we're too busy doing the stuff that's downstream? I don't think we have nearly enough skills and capability around improvement. I think that one of the most important skills that AHPs and OTs in this context can gain is an understanding how to demonstrate the impact of what you do. I'm talking about the so what. So in the 12 years that I've been working at national level to support practitioners from all the different disciplines, I go around, I go to conferences, I go to events, I go to boards, and people put up all these amazing posters of all this diligent activity they've been doing to explore improvements in the service. And they can tell me without fail what they did, where they did it, how they did it, how many standardised assessments they used in the process of doing it. Lots of stuff about the what and the when. And I say, that's great. So what difference did it make? That's the hard question. That's the hard question, and we need to get much smarter about this. In a difficult situation where people are looking at resources and what difference will it make if we take that away? Some of you may have been there fighting for a service, trying to maintain it under pressure. If you can't articulate what difference it makes, why should they worry? So, I think to be credible, to be at the forefront of that paradigmatic shift, to be moving us in the direction that our our users. We see ourselves as advocates for people who use services, don't we? Yeah? If we really genuinely believe that, then you need the skills for now, not the skills for then. We're part of the new map. And we're in that muddy water or that period of unproductive discomfort that allows other things to bubble up. People are interested in new solutions. If you want to be at the table, then you need to have some of the evidence about impact. So we've been doing some really interesting work in Scotland around falls prevention. I know there are pockets of falls prevention all over the UK. We've been learning from the work that's been done in England in particular, and looking at how we can activate people to do this at scale. So like you, I'm sure even in your own organisations, you'll know there are pockets of excellence that happen over there in that hospital, that service, that department. Are they happening everywhere? No. So how do we spread at scale? And we're looking at falls prevention as a way of bringing together our partners across health and social care, our partners in the third sector, our partners in agencies such as the Care Inspectorate, to look at how we can help organisations have the information they need to change expectations. A good example, if you like, is the care sector, actually. And Edith, who's our HP consultant working in the Care Inspectorate, worked really closely with our national falls lead, Anne Murray, and the care organisations across Scotland, Alzheimer's Scotland and Age Scotland and various other organisations, to develop guidelines and a toolkit for the care services and particular care homes across Scotland. Those care homes that have invested in doing this work systematically as an improvement approach have halved the numbers of falls in their care home. Now, 40% of the people in care homes are there because they fall. They're the frequent flyers. But with a little bit of support from OTs and other health professionals, or it doesn't have to be us, but support from somebody to implement that improvement programme, what a fantastic impact that would have. We're trying to do that with the ambulance service. We're working in partnership with them as well to change the expectation that when you come up to somebody's home, they're lying on the floor, they look dishevelled, they look frail, the first thing you do is take them to hospital. Our national e-health lead described that approach as chaos, choosing hospital as the only option. He's right, isn't he? That's what gets us into this mess. We have to be part of the paradigm shift. And if 50 to 70% of our HP resource or OT resource is hospital-based, we're not doing very well. So we need to be where the action is, and we need to think about the skills we need to take us there. I do think that we also need to see ourselves not just as the doers all the time. If we're going to enable, we have to work in strategic alliance with the people who want the same things as us, don't we? Third sector organisations, they are so pleased and delighted to work in partnership with us. In Scotland, we've created 4 AHP consultants. Each one of, well, we're in the process of appointing our third one, and we hope to have a fourth one on stream. But the first one, and you'll hear tomorrow from the first of those appointees, is Elaine Hunter, who is working in Alzheimer's Scotland. We have another HP consultant in our Alliance for Health and Social Care, which represents all the long-term conditions organisations in Scotland. We have a third post we're about to appoint in the next couple of weeks, which is in Age Scotland. And we hope to have, as I say, a fourth one coming on stream. These posts are making a dramatic difference to the way that these organisations engage and support AHPs. So if you can bear with me one second, I just want to ask the question again. So I've run out of time. I knew I would overtalk. I want to ask you the question. If you still think that the most important thing that OTs can do is deliver direct patient care, show me your hand. Fantastic. Result. Thank you very much.